Chair Rob, we're now live on YouTube.
Okay, thank you. Good morning, everyone. It is 9 o'clock, January 26, 2024. This is the Public Employee Benefit Program meeting. We'll call the meeting to order. Can we do roll call, please?
Sorry about that. I had echoes. To start roll call, Chair Rob,
Here.
Michelle Kelly,
Here.
Betsy Strasburg,
Here.
Jim Barnes,
Here.
Stacy Weeks,
Here.
Jennifer McClendon,
Here.
Janelle Woodward,
Here.
April Karin,
Here.
and then Betsy Aiello and Leslie Biddleston are absent today. We do have a quorum. Please remember to speak loudly and clearly and state your name for our transcriber. Thank you.
Thank you. We will move on to agenda item number 2, public comment. Public comment will be taken under this agenda item. No action may be taken on matter raised under this item. We have public comment, Carson. On up.
Kent Irvin, ERVIN, Nevada Faculty Alliance. Good morning. My colleagues from the South have submitted comments on the UMR remediation plan. I will speak to the master plan document revisions, agenda item 10. For transplant surgery at an approved center of excellence, travel reimbursement should be made for pre-surgery evaluation and treatments and post-surgery follow-ups visits that are medically necessary and must be done on site. Obviously, PEB isn't paying for spa vacations, but this is not that, and it doesn't make sense to provide travel for pre and post-surgery visits for knee replacements and hip replacements, but not for transplants. That's arbitrary and unfair. Next, the change of the name from low deductible PPO plan to just PPO plan is confusing since the high deductible health plan is also a PPO plan. The real problem is that the low deductible plan was changed to have zero deductible for reasons that remain unclear. The low deductible plan was meant to give a choice between the high deductible PPO and the HMO or EPO plans, reducing the deductible of the low deductible plan to zero, while adding a deductible to the HMO and EPO, which traditionally had no deductibles, blurs those distinctions and is confusing to participants. That's what should be fixed rather than the names. Finally, the PEB employer contributions with adjustments in FY 2024 are in violation of PEB's own written policy that the state's contributions will be identical for all 3 plans within a given dependent tier. Allowing that deviation from policy to continue when you set rates in March will further skew the distinction and pricing for employee premiums between the 3 plans, further confusing participants for what they mean. The policy was set for good reasons with due deliberation, and the policy should be followed. Thank you.
Thank you. Next public comment, Carson.
My name's Leanne, Leanne, Boner Welch, B as in boy, ONER-WELCH. I am a member. It is disappointing, bordering on disgust, that I'm here before you today to tell you about a UMR PEBP's appeal process that has been useless, never addressing the reason for the appeal. In early 2023, I submitted a non-assigned medical claim. I called routinely to see if it had a preferred provider. UMR could never provide me a preferred provider list. On April 19th, 2023, UMR played the claim at 50%. I called to inquire how that was determined. I had spent months not getting that information. The response was swift. I received a phone call after hours from a supervisor from UMR explaining that the claim had been reversed by a claims manager and I would be required to return the check that was already being processed or they would pursue collections. I was told in this call that the option was to start the appeals process on the basis of a plan document exception. When the first appeal was denied by UMR, that too was an insult. The request for an exception was never addressed. They had turned it over to a physician He noted an incorrect diagnosis and ignored the information on the letter of medical necessity. In the appeals process, each step was met with no acknowledgement of the request for an exception, but rather repeating that it's not covered. Let me be specific. The PEBP plan document covers the medical device annually for patients who experience the temporary side effect to the treatment of cancer. They do not cover the device for the actual diagnosis, which is a permanent condition. As the appeals process progressed, I used capital letters, bold font. I even told them what they could do. They could pay the claim at 80% because they don't have a preferred provider, or they could address why they will not make the exception. UMR denies responsibility for exceptions. PEBP denies responsibility for exceptions. No one will take responsibility. How convenient for PEBP. Don't take responsibility, give the runaround, so the member gives up. Keep in mind, members and their dependents are experiencing health issues. They have much higher priorities than to deal with all of this stress, often insulting process. Lastly, I see that Express Scripts is on your agenda. They too are dishonest, extremely difficult, and often incompetent. It is unbelievable to me that PEBP has such incompetent providers and a total lack of accountability. Thank you.
Thank you. Next public comment, please.
Good morning. For the record, my name is Bill Welch, Billwelch, and I am the husband to Leanne, the party who just spoke with you under public comment. I appreciate the opportunity to speak with you today. Now that my wife has described the issue which has unfortunately brought us to you today, my focus will be to request action by this board to help bring our request for the planned benefit exception to coverage, hopefully to a fair and equitable resolution. And I'm going to apologize in advance because I'm going to repeat planned benefit exception to coverage because it has never been addressed in any of our communications today. As you heard from my wife's public comments, it appears that neither PEB nor UMR staff have the authority to make a determination on our request for planned benefit exception to coverage. So with that in mind, I respectfully am asking you, the board of the directors of the Public Employees Benefit Program, to consider our request for the planned benefit exception to coverage. Please note the exception we are asking for is to provide the same benefit of coverage for medical device provided annually to other patients under the PEB benefit plan who experience a similar condition to the patient in question, such as the result of the medical diagnosis of cancer. We certainly support their coverage of the medical device and strongly believe our request for a plan exception to coverage in our situation is reasonable and should be approved without hesitation. The diagnosis in question with the patient that we're referring to is alopecia totality, and the condition is total loss of hair. The same thing that a cancer patient and other types of patients will experience in their treatment of their medical condition. Understanding this matter cannot be addressed by you today because it is not on your agenda for this meeting and cannot be considered under public comment, I'm requesting that you formally consider this matter at your next board meeting. I further request that this matter be considered at your board meeting in a manner which does not compromise the patient's confidentiality so as not to cause any further duress to the patient. Please direct staff to notify us of how and when this matter will be considered by the board so we may be present. My wife and I are available to you and/or your staff as may be necessary to help bring this matter to resolution. Thank you for your consideration. And on one last note, I would just like to reinforce what my wife had indicated about the process. We have made over 100 calls, multiple letters, multiple emails, and still have never had the specific issue that we have presented and was directed to present considered. I would encourage this board to seriously review PPEP staff and UMR's process for handling plan members' claim dispute issues. Thank you.
Thank you. As you noted, we cannot discuss this item today, but I will work with Ms. Glover and we will be in contact to see where we can get.
Thank you, Mr. Rupp.
Any other public comment, Carson?
Good morning. Good morning, board. My name is Margaret Kelly Osborne. I came to you last month to discuss the transplant process, travel reimbursements or travel payment for transplant patients. I appreciate you, the board, allowing GSA rates to be considered for travel reimbursement for travel transplants at centers of excellence. I appreciate you looking into that. This is a great first step. I'm here to address let's see, it's I'm sorry, I don't have this in front of me. Agenda item number 10, when it talks about the master plan document as it relates to pre-surgery appointments at centers of excellence. My question is, why are you not allowing reimbursement for travel expenses for pre-surgery appointments for transplant patients, but you are allowing them for hip replacements, for knee replacements? Last time I was here, I left a handout here as educational material, what is required of transplant patients, lung transplant patients. Evaluation and testing needs to be conducted at these centers of excellence. Not just blood tests, blood typing, general labs, serologies, tissue typing, PFTs, 6-minute walk tests, CT scans, chest x-rays, EKGs, echocardiograms, cardiac catheterizations, abdominal ultrasounds, 24-hour urine testings, bone density scans. When I talked to a PEBP member here a couple of months ago, he stated that all of this is done so they can make money. Not for the transplant patient to survive this surgery and to have a quality of life, but so the Center of Excellence can make money. I take exception to that. I believe the Center of Excellence would probably take exception to this. To allow payment for reimbursement for pre-surgery evaluations for hip and knee replacements seems to be, and not for transplant patients, seems to be unfair. What about dry runs? Most transplant patients don't receive the first set of lungs. So it's possible that I could have to go to San Francisco 3, 4, or 5 times before they find a set of lungs for me. That's 3, 4, or 5 times that I'm going to have to go to San Francisco and pay $330 for lodging, only to have to come back home and turn around and do this all over again. This is money out of my pocket, and it's just not it's just not fair. Same for counseling. The Centers of Excellence requires in-person counseling for very good reasons, and there's all kinds of literature out here why they require it. And it's this isn't a spa treatment. This is people's lives. And I just would appreciate you reconsidering this. Thank you for your time.
Okay, thank you. Any further public comment in Carson City? Being none, do we have any public comment online?
Mr. Rob, we have one online. I'll hit the slide up. As a reminder, Zoom is used for public comment only. This meeting is streaming live on the PEB YouTube channel if you want to watch the board meeting there. The YouTube link is located on the agenda. For those who have joined for public comment, your name or last 4 digits of your phone will be announced. You will be advised that you have been unmuted. Please slowly state and spell your name for the record, then proceed with your comments. Douglas Unger, you have permission to speak. Please slowly state and spell your name for the record.
Doug Unger, DOUG, President, UNLV Chapter, Nevada Faculty Alliance, and Chair, Government Affairs Committee. Thank you to Director Rob and the PEB Board for your service and consideration. The NFA and UNLV Employee Benefits Advisory Committee express our concern that the audit report for UMR still concludes that there are ongoing failures to meet PEB contractual service objectives for financial accuracy, overall accuracy, and claim turnaround time. We believe some progress has been made to address these issues, and I can confirm anecdotally that we've heard fewer complaints. Still, we do hear about delayed claims, wrongly coded claims, hung up in appeals, and inaccurate payments. We appreciate UMR's remediation plan and encourage its speediest possible implementation. Our major and most pressing concern is access to providers and provider shortages. This is at crisis levels, especially for mental health. UMR's list of mental health providers is reported to us to contain several who no longer take UMR insurance. As well, many primary care physicians and specialists in the network are so booked that they no longer take new patients. It would be helpful if this could be somehow indicated, perhaps by providers reporting no room in our practice periodically. Provider shortages constitute a much larger crisis affecting our whole state that seems to be getting worse. We hope UMR will join us in advocacy to the governor and legislature to increase exponentially state support for residencies, also for other incentives to attract new physicians to Nevada. We also remind UMR leaders that they made a commitment to add the UMR logo to the published claims PEB members must download from the claims search function in order to forward them to their flexible spending accounts for reimbursements. FSAs do not reimburse claims without the logo, so PEB members waste time adding them as they can, which is messy. This is a small, inexpensive software change UMR committed to make. All this said, we appreciate the improving communications with UMR staff and administrators. We see positive steps. Still, we urge UMR to redouble its efforts to comply fully with its contract service obligations. As the 83rd legislative session fast approaches, we also hope UMR and its industry partner representatives can join faculty, professionals, and other state employee advocates to address with state leaders the serious provider shortages now negatively affecting our state and its future health. Thank you.
Thank you. Any further public comment online?
And that concludes public comment, Chair Rob.
Okay, we will close agenda item number 2, go to agenda item number 3, PEB Board disclosure of applicable board meeting agenda items, Attorney General's office.
Good morning, Chair Rob. Thank you. This is Radhika Kanal, Deputy Attorney General for the record. This agenda item is to allow me to make a disclosure regarding conflicts of interest on behalf of the board members who are eligible for PEB benefits. Pursuant to NRS 281.420, on behalf of the board members who are eligible for PEB benefits or whose families are eligible for PEB benefits, I offer this disclosure that they will be voting on these items that may affect the benefits available to them or their family members. The law does not require abstention from voting merely because the board member or their family member is eligible for PEB benefits. At this time, I invite any member of the board who has any additional disclosure to make it now. Thank you.
Okay, do we have any further board disclosures at this time? Seeing none, we'll close agenda item number 3, move to agenda item number 4, consent agenda. All items for possible action, consent agenda will be considered together and acted on in one motion unless an item is removed, be considered separately by the board. We have the list of items on consent agenda attached in your board packet. Is there any items that any member would like to call for further discussion? Bless you. We're all good. And we'll take a motion if there's nothing to be pulled.
Make that motion. I hereby make a motion to approve the consent agenda as listed. Second.
We have a motion and a second. Any further discussion?
Excuse
no
me,
discussion,
who
I'll
was
call.
the second?
Betsy Strasburg.
Thank you.
Okay, sorry about that. Any further discussion? Seeing none, I'll call for the vote. All those in favor signify by saying aye. All those opposed? Motion passed unanimous. We'll move on to the agenda item number 5. Presentation of possible action on the status of approval of PEB contracts, contract amendment and solicitations with respect to a new proposed contract with Karam Health to maintain a network of national centers of excellence. The board previously reviewed the results of the evaluation proposed for the contract in closed session pursuant to NRS 287.04345, section 4, in the December 7th, 2023 meeting. To the extent that additional consideration of the contract requires the board discussion of confidential materials related to the contract prior to the notice of award being issued, NRS 333.335, section 7. Such portion of this meeting may be conducted in closed session pursuant to NRS 287.04345, section 4. All actions on the contracts will occur in open session pursuant to NRS 287.04345, section 5. Ms. Whalen.
This is Celestina Glover for the record. I want to just make one comment before I turn it over to Michelle. We do have one contract that if there are questions on that contract, we will need to close the session. If there are no questions, then we can move on to the vote. Any discussion on the contract will be confidential until the contract becomes public.
Thank you. She just clarified what I just read. Thank you.
Michelle Whalen for the record, item 5.1, contracts overview. Please note, I did add a note on the Willis Towers Watson contract that is effective July 1st, 2019. That was no longer charged per member per month fee. So that is a $0 contract as of July 1st, 2019. 5.2, Centers of Excellence Travel Concierge. Are there any questions on this contract? Do we need to close this meeting?
Any board members have any questions on that portion of the contract?
I'm sorry to be the person, Michelle Kelly for the record. I would like to review the contract. I think I don't have any burning questions, but I think I would like to hear you talk about the contract if that's possible.
And so we will have to close the session, but instead of closing the session right now, I want to know if we're going to have more sections that we're going to close the session for instead of closing. So we will table that discussion for right now. We'll go on to the next one.
Okay.
And see if we have to close for multiple items, and we'll let the public know what items we're closing for and then close and then come back.
All right. 5.3, there are no contract amendments. 5.4, there are no solicitation ratifications. 5.5, current solicitations. We will be beginning negotiations on the oncology management program soon. We are working through the red line contract agreement that the vendor has provided. And then the staff recommends that the contract for Centers of Excellence Travel Concierge with Karam Health be approved. So at this point, we can close the session.
Chair Rob, I have some just questions regarding the 5.1.
Okay.
chart. That doesn't need to be closed, I don't think, it's just.
No, it should.
Michelle Kelly for the record. So I just wanted to ask about the Willis Towers Watson contract. I understand it's a $0 contract. So I have a couple of questions. How are they making their money is my first question.
That would be a question for Willis Towers Watson.
Okay. And then I believe that this contract has never actually been put out for RFP. Is that correct?
it would have had to have gone out for RFP.
So this is Celestina Glover for the record. When Towers Willis Watson first came on, they were Extend Health. At that time, we did have a solicitation waiver granted. So an RFP was not conducted. It was pretty new at the time.
Yeah, I do recall.
And that contract did get extended. When it's time for the RFP, which is coming up soon, we will be going out of it.
Okay, thank you. So that was actually leads right into my next question, is that this is obviously a very complex product offering. The way the providers are reimbursed, just I'm sure the negotiations in general. So I'm wondering when, I see it's 6/30/25, but I also know that often we leave these things to the last minute and don't give ourselves appropriate amounts of time for a complex RFP. So I'm just wondering, when will that be released? And
Well, we're actually working with Siegel on the current RFP needs, and that is on my whiteboard in my office with a big old exclamation point.
I'm sure it is. Okay.
Michelle Whalen for the record, sorry.
Okay, so I mean, has Siegel indicated how long might be appropriate for the first evaluation of this kind of contract?
Not to me,
Okay.
but we can certainly ask Siegel to come to the table if you would like.
Yeah, I think I would like to I am worried about this contract. We get a lot of feedback from retirees about kind of Willis Towers Watson, and we always have, depending, doesn't matter the name, right? So just, I think it's important.
Hi, Richard Ward with Siegel for the record. The procurement and the process might be a little more straightforward than you might think, because the services are for the enrollment or for the enrollment and education of the retirees. These exchanges provide access to the individual market, and those policies and plans are available and filed and renewed independent of these exchanges. So it would be probably 3 or 4 months.
Follow-up question. So then, what will the RFP be evaluating? Just generally, I know it's.
It'll be evaluating the exchanges, or the different bidders' capabilities to communicate, educate, and support the retirees in accessing the Medicare Advantage and Medicare Supplement plans in the individual market.
And
So it's more of it's more of a service and education type of contract. They won't be contracting with providers. That's happening separately. It's just providing access to the market that already exists.
And so where does the HRA or administration of the HRA for retirees fall into this?
I'm sorry, I'm
Medicare
considering that
retirees.
part of the administration and the education and access.
So management of HRA will be part of it.
Yes.
And what difficulties do plan sponsors have generally evaluating and choosing? How many providers are there in this space that are capable, I guess, of managing, that's a more specific question, that are capable of managing a PEB size plan?
Low single digit.
Okay, low single digit. Okay.
Well, because it's a large group. There are a number of exchanges in the market, but they have different levels of capability and they serve different group sizes and they excel in different sections of the market or with different types of plans. And you're correctly noting that with a large state plan that requires a certain amount of breadth and depth and expertise.
Thank you.
And may I answer a question that you asked earlier? These exchanges generally, their compensation and their revenue comes from commissions that are built into the individual policies.
Follow-up question, I'm sorry. So then do the commissions differ based on kind of if they're an exchange or if it's kind of an individual selling Medicare plans in
Generally,
Las
no.
Vegas? No, so the commission structure is kind of built into the insurance.
Yeah, generally, yes, generally, Richard Ward for the record. Generally, with these bids, the evaluation is focused on the scope of services and the capability of providing that scope of services and performance guarantees rather than the financial aspect.
So one more question, just a general question, thinking about one of the public comments that I read. So why don't these exchanges have contracts with all of the different providers? And is that a piece that we should be evaluating as part of the RFP? Because
You will be.
Yeah, because I read a comment that said, you know, the plan they were in wasn't covered by under the exchange. And when they tried to get it under the exchange, they couldn't. So I'm just wondering, access obviously is always a big deal in Nevada. So that will be part of kind of looking at what companies are going to be best.
Right, and that access will be at the insurance carrier level. So it'll be whether it's United or Aetna or Humana or whomever, that's the contracts are at that level between the insurance carriers and the exchanges.
And generally, once they have a contract, they would offer all of Aetna's offering or all of.
Generally
United
speaking,
Health.
that's correct.
Okay, right.
Individual policies in the market that they've already filed with the feds.
Yeah.
Which vary by county or
Right.
can vary by county.
Okay, thank you.
Go ahead, Ms. Weeks.
Stacy Weeks for the record. Are you drafting this RFP?
We're drafting it in conjunction with PEB staff.
Stacy Weeks for the record. Can we review the RFP before it's posted to give feedback?
This is Celestina Glover for the record. Yes, because we will be asking for board members to be part of the evaluation committee in addition to staff and whoever else we need to include.
But I look forward to working with you on it.
Stacy Weeks for the record. I would love to be part of that. Procurements are a big part of what we do at Medicaid, and I, for the record, think that we're some things I'm hearing just feels a little bit like we can do some things maybe differently.
It's my hand too. I know it's way early, but okay.
Remember that when we come
Very
home.
good.
Yeah, really, yeah.
For the record, you're both already.
They don't have to delegate that much. What board member Weeks is saying is she's really not busy enough.
I'm gonna regret that, I know. My staff are already yelling at me.
Okay, is that,
Any further questions on 5.1? Seeing none, thank you.
okay,
Now we have to go to 5.2. We will have a closed session. I do want to give a target. It's 9:33 now. I'm hoping we can wrap up the closed session by 10 o'clock, but for the ones that we're going to ask to be excused, let's plan on being back at 10 o'clock. If we go a little bit longer, we will delay that, but let's plan to re-adjourn the meeting at 10 o'clock. Hopefully we can do it that time. Okay, thank you very much. We will go to closed session.
For those who are still watching and listening to the board meeting, I'm going to keep the slide up, and our current ETA is 10 a.m. If it changes, I'll change, that time changes, I'll update the slide and we'll come back when we are done with closed session. Thank you.
Okay, it is 10:15. We will bring the meeting back to order. We are still on agenda item number 5. And it is for possible action. I just remind the board members that anything discussed in closed session not be part of your motion or part of any further discussion. So I will entertain a motion at this point.
Michelle Kelly for the record, I'll make a motion to approve the contract for Carrum Health for the Centers of Excellence Travel Concierge Program.
April Karn for the
We
record,
have
I'll
a
second.
motion and a second. I'm sorry.
I said April Karn for the record, I'll second.
Okay, we have a motion and a second. Any further discussion?
I just have a comment. I just want to thank staff for all the effort that has gone into this new contract, new product offering. And just for the record, I urge our participants, once this contract's up and running, to really investigate and take advantage of the services that are going to be offered through it, because adding these programs to the plan really is for participants. So please use it once it's up and running, and thank you to staff and the consultants for doing and purchasing for doing such a thorough job. So thank you.
Thank you for that. Any further discussion? Seeing none, I'll call for the vote. All those in favor signify by saying aye. Aye. All those opposed? Motion passes unanimous. We will move on to agenda item number 6, Executive Officer Report. Celestina Glover, Executive Officer for Information and Discussion.
This is Celestina Glover for the record. Give me 1 second. I gotta sign this. So purchasing continues.
Wow, this is
We waste no time.
We had to have a placeholder if we don't need them.
Oh, okay.
I'll run it over.
Courier.
I just need one. Give me the hand.
All right. Again, Celestina Glover for the record. This is my executive officer report. It's an information item only. On the 16th, Ms. Whalen and I took the ODARC 100 flight to Las Vegas to meet with IRBC, that's the Interim Retirement and Benefits Committee. They have meetings essentially annually. And both PEB and PERS present to those boards that this is by statute. We have certain reports we give them. For us, it's financial statements, the OPEB report, utilization reports. We also provide them updates for any plan design changes the board has approved. And then they may request additional information after we present. And the only thing we will be sending back to them per their request is any additional plan design changes that the board will approve today. And then they've asked to look at what our communication schedule looks like. So working with our LCB analyst, they've agreed to hold off until this meeting was finished and we had all the information, so we could give it to them in one packet. They didn't really have any concerns about anything we provided to them. They did ask about our plans for 26 and 27. And I very politely said, we're still working on 25 and that we will present 26 and 27 when we have information, but that is coming rapidly because in March, I keep saying next month, but it's a month beyond that. We will begin the budget building process. We have the budget kickoff meeting. So at that point, we will be looking at 26 and 27 because we'll need to put it in our budget build. So that's coming in upcoming board meetings. Back in September, we worked with UMR and via benefits to have the opportunity for members to schedule in-person appointments to discuss their claims concerns, HRA reimbursement. And we provided information in my board report. We provided contact information in our newsletter. I provided it to the RPEN newsletter. And as of the writing of this report, which was about a week ago, the number of appointments with the UMR rep who travels up here and typically spends 2 days up here, we've had no in-person appointments. With the VIA benefits, their appointments are approximately every other week. The first month they had a scheduled appointment, the person was a no-show. October and November, they didn't have anything scheduled. December, they had 2 scheduled, one of them was a no-show. So although we've heard through public comment and through phone calls and other things that people want this service, they are not taking advantage of it. So I don't know, is it really a service that a big group of people want? Or are we talking 5 or 10 people? Obviously from the results, we're not getting a lot of takers. We are going to continue with this program. But if in the next couple of months we see no improvement, we may look at reducing the number of times that we require them to travel here. Because if all they're getting is phone calls, they can be in their office locations, taking those calls. Obviously, if we have somebody who wants to make an appointment, we'll try to accommodate that. But so I put again in this report, which is public, the contact information. So if people want to take advantage, they can call these numbers and schedule appointments. With that, pretty much the only other thing is, so the calendar for board meetings on the 26th of September, that's a tentative date. Right now, we have no reason to not stick with that date. Chair Rob has asked that we consider having that board meeting in Las Vegas. In the past, we have done that where we've had meetings in Carson and then alternate meetings in Las Vegas, since we do have a pretty good sized employee and retiree contingent down there. So we are looking at that. So something to keep on your calendars, that that's a possibility, that we may move that meeting down there. Once we know for sure, we plan that definitely, we'll definitely get that out to the board members. And then lastly, staffing. When I wrote this report, we were roughly 21% vacancy rate. We did get 2 more positions filled, but we also lost 1 person who's transferring. They got a promotion, so they're moving on to another agency. But we have opened the recruitment for that position, or we've requested that the recruitment be open. So hopefully we can get a replacement in that position in accounting. But that will leave us, once the new person starts, our 6-person accounting team will finally have 5. We've had 4, so that will help, but we're going to be looking for 1 more. That is all I have. I will take any questions.
Board Member Kelly.
Thank you, Chair Rob. Michelle Kelly for the record. Regarding the IRBC, many years ago, I was around when when that group or our group out of Carson City kind of took great exception to the wellness programs on offer, and of course they were cancelled from a high. Has there been any interest shown by that group by starting to re-look at introducing wellness benefits, comprehensive wellness programs for our members?
This is Celestina Glover for the record. I went back and listened to the last IRBC meeting before this one where Laura Rich, the previous executive officer, was asked that question by the board. They got very quiet when she answered that it was the legislature that made us terminate the program. They did not ask me that question this time. Surprise. I think that they may, since they are asking the question they have asked in the past, they may be more open. I think it'd be incumbent upon PEB staff and our vendor partners to help us get a program in place that would be well received by members as well as the legislature. So what that would look like, I don't know today. But they're not saying no at this point.
Just to follow up, Michelle Kelly for the record, if I recall correctly, they took exception to the number of sticks being introduced all at once for our members, and of obviously we're responsive to members' complaints. So, maybe a separate agenda item, but I would encourage us to start thinking about wellness programs again, because I do think they benefit our employees, and maybe take it to them at one of your sessions or something.
This is Celestina Glover for the record. I wholeheartedly agree. So I think it would be good. We just need to find the right fit for our members.
Okay, any further discussion? Seeing none, we will close agenda item number 6, move on to agenda item number 7. Acceptance of Claim Technologies Incorporated audit findings for the State of Nevada Public Employee Benefit Program, third-party administrator UMR for FY 2024 Q1, covering the period July 1 of 2023 through September 30, 2023. Tim Lindley.
Tim Lindley for the record. This audit revealed this audit covered the first 3 performance guarantees and also revealed the other performance guarantees not subject to audit that were reported in this audit report. There were 5 additional performance guarantees not met, yielding a 6% fees at risk for claims administration for a total of $79,578.15. In addition to the penalties in the audit totaling $46,420.60 for total calculated penalties for period ending 9/31/2023, 9/30/2023, totaling $125,998.75. We do have CTI on the line who will go over the audit report. After CTI has reviewed the audit report, we will open it for the board can ask questions of CTI. And in conjunction with this audit and in conjunction with this agenda item, we do have a UMR remediation plan that was requested in a prior board meeting. And with that, I want to pass it to CTI.
Good morning. For the record, my name is Joni, Joni, Amato, Amato. And the scope of the first quarter 2024 UMR audit included claims processed during the period of July 1, 2023 through September 30th, 2023. And as in prior UMR audits, it included both medical and dental claims. The medical and dental claims paid during the audit period totaled approximately $55 million and included approximately 218,000 claims. The audit included 4 components: the quarterly performance guarantee validation, 100% electronic screening with 50 targeted samples, a statistically valid stratified random sample of 200 claims, and data analytics. In our auditor's opinion, UMR's financial accuracy and overall accuracy performance decreased this quarter, while claim turnaround time within 14 days improved, and claim turnaround time within 30 days remained the same when compared to the prior quarter audit results. The performance guarantee for claim turnaround time of 92% processed in 14 days was met this quarter. The performance guarantees were not met for financial accuracy, overall accuracy, and claim turnaround time of 99% processed within 30 days. And as Tim mentioned, this results in a 3.5% penalty of the administrative fees for the quarter, or $46,420.60. We recommend reviewing the financial errors identified in the random sample audit to ensure that root causes have been identified and claim processor training or any system corrections are made where appropriate. Additionally, we recommend the review of the electronic screening and targeted sample results to focus on potential recovery and process improvements in the categories identified with errors noted. Thank you.
Thank you. Any questions from the board? Okay, it is listed for possible action. I think we want to go through the remediation plan before we go to the action.
If we want to accept the audit findings and then open it to the remediation plan discussion.
All right. Go.
Make a motion to accept the, Michelle Kelly for the record, make a motion to accept the audit findings by Claim Technologies for Q2. Q1.
Second.
We have a motion.
Betsy Strasburg, second.
Yes, thank you. We have a motion second. Any further discussion? Seeing none, I'll call for the vote. All those in favor signify by saying aye.
Aye.
All opposed? Okay, 7.1, UMR remediation plan.
Good morning. I'm Helmut Braun from UMR, HELMUT, BRAUN. I've got with me Nathan Meyer, who also is with our organization, and Darren, who runs our operations for the claim operations. I guess I'd just like to start and say, we are deeply committed to this relationship, okay? We've been working hard to try to make progress on the requirements as per the contract. Okay, I think we made some progress in some areas, not as much as we'd like to in some others potentially. But we certainly have committed resources to this and continue to commit resources to this. We've had this operation actually in our organization when you include the acquisition for 10 plus years at this point in time. And we've had the same team, which Darren has run, who has come along to work with us today or to answer any questions today, working on this same organization, the same team in place, okay, during this entire time. Now, obviously, team members come and go and the team, migrates a little bit, but in general, the core team that's been working on this from a customer care perspective and from a claim payment perspective has remained in place. And since we've migrated this over onto our UMR platform, our CPS platform, all we've done is sort of add resources. Okay, so we have increased our resources. We were probably somewhere in that 45 to 50 range when it was on the Health Scope platform. We're now probably well north of 80 employees that are working on this plan. All right, so we have taken on some additional services in that time too. We are now actually doing the care management services. We're doing all the network services. Some of those things were things that Health Scope didn't do. Okay, so we do sort of have the full scope of responsibility. The details are in the report, so I don't know that I need to walk through this sort of on a line by line or page by page basis. You've all had a chance to see that. And I think maybe at this point, I'd be more than happy open to questions. We gave you a little bit of information about the total amount of the scope that we do, the number of claims that we process, the number of phone calls that we take. And so you can see it is a very large number of claims. It is a very large number of calls. And, I would tell you that, our effort really is to sort of help support the plan and make sure that we keep it cost effective. All right. And so we do have a lot of efforts in place to make sure those claims are well managed. And we have a lot of people that are focused on trying to make sure those claims get paid correctly according to the contract.
Michelle Kelly for the record. Can you walk us through what the remediation plan is? Like, I understand you've given us a written document.
Yeah.
I'd like to hear you talk about it.
You know what? I'm actually going to go ahead and Darren because he's going to be the one that's going to be responsible for it. So I'll let him take you through some of the bullet points on the key remediation plan. All right.
So if you've had an opportunity to look at the remediation
Can I get
plan.
your
Oh,
last
I'm sorry.
name and the spelling?
And Darren Ashby with UMR for the record. DARRENASHBY. All right, if you had an opportunity to look through the remediation plan, you'll see there are some key initiatives outlined, and we'll kind of go through those to kind of talk through what we're doing. As we go through it, you'll see a common theme of the various areas that we are putting in additional steps of review from an auditing standpoint. Also looking at adding additional resources to the teams, and then also looking at just the additional resources and then the auditing. So as we look at the financial accuracy portion of the remediation plan, the areas that we're looking at there, we're taking errors that have been identified through our internal audits, as well as errors that have been identified through CTI. And we're taking that and comparing it to additional repetitive type errors that we may see come through on a daily basis. We have enhanced those audits and increased them. And one of the additional steps that we're taking is we actually have our leadership team that is now looking at those errors that may come through on a daily basis. And they're meeting with the staff to go through with counseling sessions. And then if they identify that a particular error is happening across multiple claims processors, then we're putting together training modules. And then on a weekly basis, we pull the staff together and together go through that training process and going over those errors to make sure that there's understanding and also to get feedback from the claims processors as to what they need from us in order to better do their job and or avoid making these errors going forward. As far as claim turnaround time, as Helmut mentioned, we've added additional staff. Originally, we had 14 claims processors and on the dedicated team, and we've now increased that to 20 on the dedicated team. In addition to that, we also have enlisted additional resources to help us to manage that inventory and to make sure that going forward, we improve the claim turnaround time. And we have actually already seen results from that and been able to significantly reduce the overall inventory as well as reduce the turnaround time that it's taking us to get those claims processed.
Can, Chair Rob, is it appropriate to ask questions as we go, or should
Yes,
we hold?
go ahead, please.
So with regard to the inventory, it's my understanding that most of the providers would submit digitally or their bills digitally. Is that correct?
Correct. We get about 92% electronically.
Okay, and so then that's the queue you're referring to. So every claim kind of comes in and it sits in a queue and it needs proctoring?
Yeah.
I'm sorry.
Yeah.
I'm just trying to understand the process. Once that bill hits the queue, what is the process?
Yeah, so what happens is, like I said, 92% come in electronically. The other 8% come in some other form, either, faxed in, mailed in, whatever. Those are converted. That usually takes 1 or 2 days. And so within 1 or 2 days, they're formed into an electronic format. And then they all go into the queue on whichever day they receive. At that point, it goes through a repricing process. Okay, so the claim has to get repriced. And then about
is that manual or
No,
automatic?
That's an automatic repricing process. Now, there are some manual kickouts, okay, but for the most part, it's automatic. And then those ones that can't get processed automatically, we're probably somewhere in that 60% that automatically adjudicate. Those get kicked out to processors. They have to look at those and review those, okay? And then they approve those claims and they go on through the process. Okay, now the payments actually go out, we're probably somewhere in that 85 to 90% go back out electronically to the providers as well. Okay, and they have several different options for how they can receive their claims or their payments electronically. They can sign up with various clearinghouses. Most of them, like I said, are signed up and do receive that, as well as their remittance advice, all come to them electronically.
Thank you.
Okay.
So then, I'm sorry, so then coming back to the enhancements. So the staff, the 14 that have gone to 20, those staff are reviewing the kickouts?
Yes.
So the repricing that doesn't happen automatically, they each then go in and what causes kickouts?
Well, it could be repricing. It also could be other edits. Okay, so maybe it requires a referral, or maybe there is an authorization that has to be verified, or there is a claim type that we need to do a counter on, or go back and review historical claims to make sure something else hasn't occurred that would impact that payment. It may just be a review of the claim. For example, some hospital claims have complex billing situations, and we got to make sure that it's in accordance with the contract and it's more than the computer can do by itself. So we have somebody manually review those.
Okay, and so I think you said about 90% go through without kicking out?
About 60%.
60%.
Yeah.
So I'm sorry, just going back to the report. So I think there was 257,000 claims in the quarter of the audit.
Yeah.
And so only 60% of those go through automatically. And we've
Right.
got now 20 staff working on the kickouts.
Correct.
And so when something kicks out, what's the process there just the general process that the staff member would take?
Well, it comes to that staff member, so they'll get a queue. Let's just say there'll be claims lined up for them to look at. It'll come up on their screen. That screen will show whatever edits that claim requires. Okay, so it may say, you need to find the authorization, match that with an authorization before it gets paid. And then they go ahead and say, okay, I found this authorization. They do the matchup and then they release that claim. Okay.
Yeah.
Or it may say, we need to get additional records. We may need an I-bill from the hospital before we can pay this claim, so that we can, an itemized bill. Okay, so, but again, there's various, edits that could take place. It may say, check for coordination of benefits. So, like I said, I don't know, do you know how many edits there are, Darren? There's probably dozens, right?
Dozens of them, yes.
Yeah.
So on average, I'm sure you've done the data collection. On average, how long is one staff member spending on one kick out?
So, our goal is for staff members to process between 12 and 18 claims per hour. All right, so we could say an average of 4 minutes. All right,
So that's a lot. So even though you've added resources, that's still a lot of kickouts for 20 staff members.
well, we've added enough resources so that we're able to manage that. Okay, that's why we added the resources. I mean, our claim inventory, a year ago, we were probably at that 20,000 level. Right now, we're probably around 7,000 claims in-house, and we get about 2,000 claims a day. Okay, so we have 3.5 days worth of claims in inventory. Okay, that's pretty good turnaround time. All right.
So this report is Q1.
Yeah.
What Q are we in now?
We're in Q3.
Thank you. So Q3, so internally, you'd have looked at Q2.
Yes.
Have the additional resources you put to this area, is it making a significant difference that at the next meeting when we get Claim Technologies audit report, am I going to be smiling or not? Or at least neutral?
We've definitely made improvements in the inventory that was on hand, okay, and that should be reflected in the turnaround time as well. Okay, so that inventory has consistently gone down over the course of the last 6 months.
So do your metrics show that you're meeting the
I would say
agreed upon?
we're likely meeting the 10-day or 14-day, okay? But the challenge, the 99% in 20 days, that's a very challenging metric for us to hit, just because we have quite a few claims where we have to get bills from hospitals or detailed records from hospitals and review those. And, it just exceeds that 1% number. So we normally don't agree to 99%. Normally we're at 98. That's our typical PG.
But you agreed to 99.
Well, we agreed. I understand, and we're striving to meet that, and if we don't, we pay the penalty, right? So, but it's not like we're missing it by 10%, we're missing it by 2% or 3%, so. Again, and we're working with the hospitals to make sure they know what our status is on those claims. We have a weekly meeting with Carson Tahoe, we have a weekly meeting with Renown. Okay, so they know where the claims are in the process, but it's not like they're not angry because they're not getting paid, they know we're doing our reviews.
Just to follow up on that though, I think that many of our complaints I'm sure, I don't know about the hospital complaints, but what we did hear from were individual providers who do live hand to mouth. And so I think many of those providers, especially out, where there aren't a lot of providers, were saying, hey, if we're not getting our bills paid, we can't feed our family and we're not going to provide services anymore. It's kind of that simple, right? So how about those individuals?
I think those have been improved significantly. There were some turnaround time issues earlier in the year, last year, but towards the end of the year, those have definitely improved. Okay. And again, we're hitting that 93.45% in 10 days. Most of those claims are not the complex claims that take a long time. So those should be getting out. Now, again, we can get you some better measures. I know I did look at December. December, didn't you have some numbers there? And was it 90?
In 10 days, it was 94.2. And then in 20 days, and these are business days, it was 98.71.
Yeah, so we do have some improved numbers and, what we did, we looked there at claims received in December and then when were those actual days? And those have been in the city disclosure to you. So we would have hit the one metric, we would have still missed the other one by 0.3%.
Betsy Strasberg, thank you for presenting the remediation plan, and I do see that you stated that in the last year, there's been a vast improvement, and thank you for sharing all the process changes that you have done. The one thing I would like to ask you is in order to track your improvement over time, do you have internal goals for your staff, and are they time-bound?
We do have internal goals for our staff and they are time bound. So basically, we measure our staff on a weekly basis. We receive both quality and turnaround time reports on a regular basis. And so and that's one of the enhancements that I talked about earlier, is that rather than looking at those weekly, we've now started to look at those daily. All right, and so now what we're trying to identify so that we can remediate quicker is what errors are they getting today from yesterday, and what can we do to help to remediate that immediately so that they don't continue to make that same type of mistake throughout the balance of the week and or the balance of the month. And so those are the timeframes that we have in place right now, and that's kind of what we're doing to make sure we look at the inventory on a daily basis. Helmut's part of that. He gets that update every morning as well. And so we have all leadership heavily involved in looking at that inventory on a daily basis, making adjustments where we need to make adjustments to make sure that we're hitting the numbers that we expect to hit on a daily basis.
Thank you.
Mr. Khan, for the record, just looking at some of these findings, a lot of them are tied to manual processes. What are you doing to reconsider that approach? Maybe look at it, taking more of a systematic approach to eliminate the manual intervention. And has that been considered to see if you can't improve upon those SLAs?
We do have a team that is working on automation, okay? And so we're looking at the claims, we categorize them, figure out which claims in certain categories have the most manual processes, and we're working our way down that list, trying to improve that number. So, hopefully that 60% automated number goes to 65 or 70 within the next year, and that should help us.
Remember, Kelly.
I just had a follow-up. So why are claims manually processed? I'm sorry, I like to start at the beginning. So you've got automated processes, but what causes a claim to have to be manually processed?
Well, there are just certain things that need to be looked up that, we haven't been able to automate so that the computer does it automatically.
Is that kind of plan document specific then? Is it PEBS plan specific, or is it generally?
It's a combination of plan document issues, and it's a combination of network challenges sometimes with the complexity of the network contracts, the requirements and how they're paid. Okay, so I will tell you that, the automation in the PEB plan is at the lower end of the spectrum for us. Our average automation is well above 80%, okay? And this one's, like I said, in the 60s. Okay, so we are looking specifically at things within the PEB plan that we can hopefully automate and bring that number up so we get, let's say, hopefully into the 65-70% range within the next 12 months.
Thanks.
Stacy Weeks for the record. Thank you for the presentation. Is there a way for you to add to your plan here, that automation?
Yeah,
Instead of it all being
we
manual?
can add a
invest in that?
paragraph about that. Yeah, not a problem.
And then the other question I have is, at least just keeping it simple and high level, when I hear delays like this, I think, oh, we have too many PAs in our system, because often that is a problem, and that is why and so I'm curious, have you looked at your PAs on some of your services and trends to see, are 90% of these PAs often just being approved and removing those PAs? Because that is the burden, and that creates a lot of delay in payment for providers. And often I know plans use PAs to sort of control costs sometimes, and I would say sometimes that's inappropriate. But I think there's probably opportunity to look at your PAs and think about removing some of them that obviously are delaying processes.
Yeah, and those are plan specific, so the PEB plan.
I'm sorry, can I get your name, please?
Oh,
This is-
go ahead.
This is Nathan Meyer, for the record, from UMR, MAIER. And so I was just saying that the PA rules are set by PEB, and I know Rhonda works back with our clinical team. We make recommendations back to PEB staff about, are there things that require authorization that we see approved pretty much on an automatic basis that don't make sense and they create unnecessary delay. So that is a process that I know that we, communicate back with PEB staff as we're looking at plan changes. And so, yes, that is something that we look at.
Stacy Weeks, one more follow-up. Can we maybe add that to this as well? Is that you're going to do a look at categories of services and come back to us with recommendations?
Sure. Yep.
Thank you.
Any further questions?
I think we've talked kind of about the claims, Michelle Kelly for the record, we've talked about the claims, but we didn't talk about customer care. I think that was the next metric.
Yes, so for Darren Ashby, for the record, UMR. So for customer care, again, kind of along that same theme of looking at resources, looking at enhancing our quality audits and the number of audits that we do in order to impact change here. So you'll notice that originally we started off with 18 call agents, and we increased that to 22. And as we continue to review the process and the work that was associated with not only the volume of calls coming in, but then the work that creates when that call does come in, we recognize the need to make adjustments in that staffing model. And so we went through an iteration of 22, then to 27. And so we are now sitting at 31 call agents that take calls and also resolve issues that come up from those calls, the work that needs to be done. And we are meeting our metrics as a result of that increase.
Just a follow-up question on Michelle Kelly for the record. So are those dedicated agents to the PEB plan? So they're trained in the PEB plan document specifically, all they do is PEB, or are those 31 agents assigned to multiple clients, or just it's a general queue?
Those 31 agents are dedicated to the PEB account, servicing the PEB account.
I'm impressed with your ability to bring on staff. I'd like to know. State of Nevada has not, we're working on that.
It is a big job, okay? Obviously, we have a pretty large organization and we have a talent acquisition team that helps us with that process, and it's planned in advance. And we sort of predict how many people are either going to leave or transfer into other positions in advance. And so we get classes scheduled and we start planning those classes 60 to 90 days in advance of the time we're going to have the class in order to fill those classes with qualified candidates. So.
Michelle Kelly for the record. I'm sorry, I feel like I'm monopolizing this, so please ask questions, other people. So I think there's been a theme in public comment for the last few meetings of the appeals process. And I understand the appeals process is a shared process between UMR and PEB. So are these 31 agents also dealing with appeals, or can you talk about the appeal process generally and how it might relate to the contract?
Well, so we have a separate appeals team, okay? So every appeal that comes in, gets assigned a case number and somebody specifically works on that appeal. We probably have 80 to 100 people that work in the appeals team. Now, they're not assigned to any specific group or whatever, but those appeals come in and obviously we review those appeals. And in many cases, it's a question of whether or not the benefit's payable or not payable. And it's, obviously sometimes we've given misinformation to a member. When we do, we correct that or fix that, okay? In some cases, it's just it requires a plan exception. If it gets to the point where it needs a plan exception, then we come back and work with the PEB staff and ask if a plan exception might be available. If not, then we communicate that back to the member. But there's, it's a process that certainly many members who don't get their claims paid and it's not covered by the benefit plan don't feel good about the result.
So I have just a follow-up. So I had a personal issue
Yeah.
where I didn't think my bill was paid per my understanding of the plan document.
Yeah.
So I called and said, hey, this is wrong. You know, this is my understanding of the plan document. And I got to say, the agent was very nice, very professional, but nothing happened. And so then I just came back from vacation, and this is 3 months ago. I just went ahead and paid Quest. Of course, it's always Quest, right? I paid my the share of that UMR was saying I owed,
Right.
and I came home to a check because I guess 3 months later, I don't know if it was caught in an audit or the appeals process maybe is invisible
No,
to me.
If
but-
if you didn't file an appeal, an official appeal, then there would not have been any appeal process. Now, you know, maybe you talked to somebody and they initiated some sort of provider review or some sort of, you know, review of that billing process and found something in that process and figured out that, you know, it should have been different. But unless you actually initiate an appeal, a member appeal.
I think I did. You have to do that through the web, right? I
You
mean,
can't
some of
do it
this
through
is
the
as
web,
clear
or
as
you-
mud.
Or you can
honestly.
actually mail it in.
I'm sorry, can I get one at a time speaking? You both are talking over each other. Thank you.
Sorry. So Michelle Kelly here, I was just saying, I'm pretty sure that I was told there was no repricing anymore and I did have to do an appeal and I think I did it online, you know, I mean, honestly, it was $40. It wasn't worth my time.
Yeah.
As I say, I'm pretty sure I filed that and then I looked out and I couldn't find anywhere where it was listed and
Okay, well, we can check and see if you did actually file an appeal and Jesse, I'm assuming you can look into that and get her the results of what happened that, but
well, I think I got paid because I got a check.
Right, I
that I
understand.
wasn't expecting.
I understand that, but I'm just saying, you know, we can make sure, normally though, if you filed an appeal, you would have gotten a letter telling you the results of that appeal.
Board Member Weeks.
Stacy Weeks for the record. So it is disturbing to hear some of the complaints, and I get it, and not every time is it gonna be perfect, but I do think we need to look at our customer service, not just at your shop, but possibly at PEB. I am concerned. People just sometimes want someone to listen, to be empathetic, even if the answer is no. And I'm not sure what our transcripts look like for our call centers and how people respond to people. But I'm just wondering if we could do a review where you guys maybe we all start recording somehow some of these conversations. And when there is a complaint, someone is doing a quality check on that. And going back and looking at what went wrong, how maybe the agent could have explained something better. What was the follow-up communication? Sometimes people just want information on why. And if the answer is still no, if we're not explaining things, people will get frustrated. I mean, it's their healthcare, it's their life.
Right.
So I think we just need to look at how we're treating the recipients. And I would like to think about recording those or some way we can do a quality check on what actually happened and then train staff to do something different next time. That's something I think we need to think about, not just at your shop, but possibly at PEB.
So.
Darren,
Go ahead.
I was gonna say Darren Ashby for the record. So that actually is part of our process. So when we do get a complaint that comes in, we do record all of our calls. So we have the ability to go out and pull that call. And the team lead will listen to the call. And if there is remediation that's needed, we need to talk to the rep about how they handle the call or information that was provided that takes place at that time. So that is a process that is currently in place.
And we do audit a certain number of calls every week. Okay, so every week every agent gets, you know, a couple of calls a week audited, so, you know, 8 per month. So each agent is reviewed to make sure that they're handling situations appropriately.
And if you do look, this is Nathan Meyer for the record. We provided some call satisfaction rates for participant calls. And so 97.4% of callers are satisfied with the service. So that is something that we track in addition to the audits.
Stacy Weeks for the record. So then maybe can PEB look at their process and what's going on with recipients? Because I'm very concerned about some of the feedback we've been getting on their experience.
This is Celestina Glover for the record. Part of our training process, our calls are also recorded. They always have been. So that is part of our training process. And if our members are giving or our employees are giving out incorrect information, obviously they're what the information should have been or how the call should have been handled. So that's been an ongoing process for years.
Stacy Weeks for the record. I'm sorry, I'm gonna hit this one again, but it's not going well. I mean, you can tell by the way people come up here and talk and how their experiences. I mean, I heard it earlier, and I know that's not on the agenda right now, but we have to look at that. Yes, we're not gonna cover everything. We can't afford everything, but I do think the respect and sort of the way we treat the recipients when they call, even when we have to say no, and I just, something is not going right in that process. So I'll just stop there. Thank you.
So I just want to follow up on Board Member Weeks. I would actually like to request an agenda item where the board gets to review the totality of the appeals process, both the UMR side, who's responsible for what, including the PEBP side. And I think that, it's been a continual noise that we're hearing, and I, with your permission, Chair Rob, I think it would really benefit the board to understand from A to Z of the appeals process.
We're happy to do that.
But just on bringing it back to UMR, I'm very pleased to see that the metrics for customer care have improved. And as I say, the people I've spoken to, the few times I've had to call, have been good. And it was good to hear public comment that anecdotally complaints, that pass around campuses and from participant to participant have decreased. So I think some of what you have done has addressed the concerns. So I look forward to continuing to see improved metrics on that.
Thank you.
Okay.
And with that, I'll make a motion to accept the UMR remediation plan as presented today.
It was not listed for action.
Oh, we don't even need to.
Okay.
What's that?
It's part of both.
Yeah, it's part of the. Whoever took action on number 7, so the remediation plan.
Just to be safe.
Yeah.
Just to be safe.
Well, we can be safe. We have a motion.
Can I amend, this is Stacy Weeks, can I amend that motion? I asked for a couple things to be added to the remediation plan. I'm trying to remember what they were. Did you guys take notes on those?
Yeah.
I'm sorry.
The
Yeah. the
automation was one.
Prior authorization.
Prior authorization review.
We accept the the remediation plan with the inclusion of the additional metrics requested by Ms. Weeks.
Okay, so we have a motion. And
Stacy
second.
Weeks, I move. Second.
Second was Board Member Weeks. Any further discussion? Seeing none, we'll call for the motion. All those in favor signify by saying aye. Aye. All opposed? Okay. We'll move on to agenda item number 8. Acceptance of mental health parity, addiction equality, equity act report, including possible action on, but not limited to, the following items. Celestine Glover.
This is Celestine Glover for the record. About a year ago, I'd say in December of 2022, November and December, the Mental Health Parity and Addiction Equity Act, at the time, government plans could opt out. That option has changed. And I believe that has been reported in a previous board meeting. PEB had always intended to comply with the requirements of the act, but they had intended at the time to opt out. Once we determined that we could not opt out, then we requested that a review be done of our plans to indicate where we meet the requirements of the act and where we do not. So the item coming up, we've asked Siegel to do that review. They have completed it. What they have included in the packet is a high-level executive summary to tell you where we're good and where we're not. Essentially what we're missing, what we need to change. The agenda item itself is information because the things they bring up are gonna come up in the plan design and the MPD document of actual action. So with that, I will turn it over to you, to Siegel.
Okay. Richard Ward with Siegel for the record. At the last meeting, the board reviewed a specific plan change in a copay for other outpatient services as a result of our review. And what we have here is a further review of clarifications, for want of a better term, in the plan document that Executive Officer Glover mentioned will be addressed more specifically in a later agenda item. I'll turn it over to my colleague.
Thank you very much. Amy Dunn for the record. Good morning, everyone. Thank you for having us. Today, we're here to talk about the key findings of our mental health parity non-quantitative treatment limitations review, also known as NQTLs, within the plan documents for the consumer-directed health plan, for the low deductible PPO, and the exclusive provider plan, or the EPO. And so by way of background, the Mental Health Parity and Addiction Equity Act generally requires that group health plans ensure that financial requirements and treatment limitations on mental health or substance use disorder benefits are no more restrictive than those that are on medical surgical benefits. So kind of in two different areas. Non-quantitative treatment limitations are non-numerical limits on the scope or duration of benefits for treatment, for example, pre-authorization type of requirements. Additionally, although the regulation does not require plans to cover mental health or substance use disorder benefits, if they do, they must provide mental health or substance use disorder benefits in all classifications in which medical surgical benefits are provided. And those classifications are inpatient, both in and out of network, outpatient, both in and out of network, prescription drugs, and emergency care. Now, PEB is not alone in all of this. Plans throughout the United States are working with their administrators to advance continued compliance with more recent parity requirements, including ensuring comparative analysis are documented, making sure modifications are done and needed to assure that the written descriptions and administrative operations conform with one another, as well as to the parity rules. And so now I'd like to walk you through some of these key findings that we had within our review. So in addition to the plan design changes that were approved in December of 2023 to the low deductible and to the EPO plans, our recommendations generally include following actions: modifying or removing certain exclusions or limitations, clarifying certain day limits or visit limits, clarifying certain benefit descriptions, reassigning certain benefit classifications, and I've got a kind of a group of other considerations. So I'd like to walk you through some of our findings now. So under modifying or removing certain exclusions or limitations, and I would say this is where the bulk of our findings fell, we've made the following recommendations. Under the exclusion of for attention deficit disorders, we have recommended removing this exclusion as there are restrictions on care for this specific diagnosis that are not applied to medical diagnosis. And as PEB is covering prescription drug medications for treatment for attention deficit disorder, it must provide coverage in all of those 6 of those benefit classifications I just described that are under the regulations. The exclusion for hypnosis or hypnotherapy, we recommended moving this exclusion under general exclusions, as now it only appears under the behavioral health exclusions. So it's clear that it applies equally to both mental health and substance use disorder benefits, as well as medical and surgical benefits. The exclusion for marriage and couples and or sex counseling, we recommend clarifying the exclusion for marriage and couples counseling that it will not limit individual mental health counseling for an otherwise covered mental health condition. We also recommended either clarifying or removing the exclusion for sex counseling, as sex counseling could be interpreted as an exclusion aimed at gender dysphoria. The exclusion for cognitive therapy, currently the plan documents exclude coverage for cognitive therapy unless it's related to a short-term services necessitated by catastrophic neurological event to restore functioning of activities of daily living. And we recommend revising the plan documents to include an exception to this exclusion for medically necessary treatments of a mental health or substance use disorder condition. Talk about the exclusion for sleep disorders. The plan documents now cover medical treatment for sleep disorders. However, there's an exclusion for cognitive behavior therapy for sleep disorders. And so we recommend adding an exception for medically necessary treatment of a medical or of a mental health or substance use disorder condition. There's an exclusion, plan documents have an exclusion for Mylu therapy. If you're wondering what that is, Mylu therapy is a structured group treatment method for mental health issues using everyday activities and a conditioned environment to help people with interaction in community settings. And so we recommend clarifying this exclusion unless this care is otherwise medically necessary. So just a revision there. When it comes to exclusion for food addictions, we recommend removing this exclusion. Federal enforcement generally tends to raise questions about plan provisions that may exclude medically necessary treatment for eating disorders. There's also an exclusion for weight management. The plan documents include a pretty detailed exclusion for weight management, but they include an exception to that for exception for that in conjunction with medically necessary treatment of anorexia, bulimia, or acute starvation. That's a narrow list. We just simply recommend changing that language to include eating disorders or if they are considered, because they are considered a mental health diagnosis, to just rephrasing that to say, for medically necessary treatment of an eating disorder. For speech therapy, the CDHP schedule of medical benefits includes benefits for speech therapy for an injury or sickness that is other than a learning or mental disorder. And so limiting speech therapy for a mental health diagnosis may cause problems under mental health parity. Speech therapy is commonly used for treatment of mental health conditions, most notably autism. As the limitation is only presented in the CDHP plan and it's not in the low deductible or the EPO plan, it's possible that just may have been an inadvertent oversight. So we recommend removing that limitation for speech therapy for a mental disorder. Also for alternative or complementary healthcare exclusions focusing on chelation therapy, that has to do with heavy metal toxicity or poisoning. Plan documents exclude coverage for chelation therapy, except as may be medically necessary for treatment for acute arsenic, gold, mercury, or lead poisoning, or for diseases due to clearly demonstrated excess of copper or iron. It would be appropriate to exclude chelation therapy for all conditions, but it raises mental health compliance concerns to allow it only for certain medical diagnoses, as it can be prescribed for the diagnosis of autism and ADHD. So we recommend adding that to the list of exceptions for medically necessary treatment of a mental health diagnosis. Exclusion for vitamin B12 injections. Who knew? The plan documents exclude vitamin B12 injections, except under certain medical conditions. For example, one of them is pernicious anemia. And there are others. Allowing B12 injections for certain medical diagnoses while not allowing them for any mental health diagnosis, for example, such as anxiety or depression, could present issues under mental health parity. So we recommend amending this exclusion to make an exception for mental health and substance use disorder conditions. So those were the main ones for that category. I would also say for clarifying certain day limits and visit limits. We note that the EPO plan and the low deductible plans limit the coverage for rehabilitation and habilitation facilities to 60 plan days per plan year for physical or occupational and speech therapies. The plans also require pre-certification for habilitative and rehabilitative therapy visits, exceeding 90 combined visits per plan year. Since the visit limits and the day limits don't appear to apply, again, to substantially all medical surgical benefits, it would not be permissible to have a visit limit imposed with respect to services provided in this classification for the treatment of mental health and substance use disorder conditions. And so we recommend adding a consistent exception throughout all three of the plan documents to state that visit limits will not apply to medically necessary treatment of mental health or substance use disorders. We want to also clarify certain benefit descriptions. For example, for case management, the plan documents describe a case management program. And so we recommend revising this plan language to make clear that a disability resulting from mental health or substance use diagnosis will be covered under the case management program. We note that this is a voluntary program, but the plan document does not clearly indicate that case management is available for mental health or substance use disorder. It doesn't exclude it either, so we just think that enhancing that language would be helpful. For rehabilitation therapy, inpatient and outpatient, plan documents exclude coverage for speech therapy for conditions of a psychoneurotic origin. That language is a bit unclear if it excludes treatment for autism or other mental health conditions. So our recommendation is to remove conditions of a psychoneurotic origin to the extent that they may limit mental health conditions. Exclusion for sexual dysfunction, the plan documents include an exclusion relating to, among other things, drugs, medicines, procedures, services related to sexual dysfunction. However, under the family planning benefits for the schedule of benefits in the CDHP plan, it states that procedures related to sexual dysfunction may be covered. So we recommend clarifying this plan language for services and for drugs related to sexual dysfunction within all three of the plan documents consistent with the parity regulations. For enteral formulas and special food products, the plan documents allow enteral formulas and special food products for a person with inherited metabolic disease up to a maximum benefit of $2,500 per plan year. But there's no similar coverage for a mental health condition, such as an eating disorder. So we recommend allowing enteral feedings for mental health diagnosis without the $2,500 annual maximum per plan year, as plan years are not able to impose a dollar limit on mental health substance use disorder type of diagnosis. One part too, we thought we needed to reassign a certain benefit classification for partial hospitalization. The plan documents specifically list partial hospitalization as an inpatient benefit under the pre-authorization requirements of the plan. Partial hospitalization should really be reassigned as an outpatient benefit and referenced accordingly through the plan document. And finally, I would call other considerations. And these two are really kind of put together here. I would say that the treatment plan required for the treatment of autism. The plan documents state that any treatment of autism spectrum disorders must be identified in a treatment plan. And the plan terms are written as required under state law. Well, requiring a treatment plan, actually in addition to a physician's order and discharge plan under the CDHP plan, for behavioral health services, when there's no similar requirement for medical services, raises federal mental health parity concerns. There is a Department of Labor and the Department of Health and Human Services have put out a publication called Warning Signs on NQTLs. And this specifically mentions this as problematic when there is no similar handling required for medical surgical treatments. I would also say a second part of this is looking at ABA therapy, for example, which is known as the Applied Behavioral Analysis or ABA. Per Nevada statute, that is considered a medical benefit. Federally speaking, a federal auditor may not agree with that approach. They may consider that an actual mental health type of a program. So from here, I think the plan should really coordinate with parties, for example, the administrators, regulators, legal counsel, and perhaps also the Department of Health and Human Services regarding questions as related to this appropriate condition coordination from kind of federal and state issues. In requirements related to autism, which is a mental health benefit subject to federal parity requirements. And finally, in closing, I want to point out that last summer, the summer of 23, new proposed rules came out for mental health parity that propose amending existing regulations. And they establish new minimum standards for these NQTLs, including additional documentation and data collection standards. Again, these are now proposed rules. We have not yet heard any final, but this is, like I said, PEB is in this with everybody else right now. We're all learning and this law is really evolving and growing. And so stay tuned, I would say, for more updates as we go.
Okay. Thank you for a thorough review. Any questions?
Of course, I'm sorry.
Chair Kelly.
So yeah, this was Michelle Kelly for the record. This was very thorough, and excuse me for my ignorance because I'm about to ask a question that I'm not actually comfortable with. But when you kind of going through each of these items, it jumped out to me that the PEB plan has limitations for what I would say are medically necessary things like, you know, specifically looking at physical therapy, right? 60-day limitation, but you're saying that that same limitation can't apply to mental health. And so that seems to me that we're going to get into a situation where medically necessary rehabilitation isn't covered to the same extent that mental health rehabilitation is covered. And so I guess my question is, I know you're looking specific to this law, but as you went through, did you turn an eye to equity issues as well, just between mental health and regular medical? Because it seems to me like, I know we're going to go through the plan document and enact some of these changes. I guess I'm just concerned that we then end up with a plan that's a little misshapen because we have to comply with the law on one hand, which is, I would be remiss if I didn't say, which is going to cost the plan potentially significant amounts of money. But then on the other hand, we've got medically necessary rehab for structural issues of the body, if you want. I'm not sure what the right term is, that aren't going to be covered at the same level. So I just wonder if you can comment on that.
Amy Dunn for the record. It's a lot to unpack in the question, but again, nothing that all other plans right now are really looking at and facing. The rules look to see, as long as the mental health benefits, again, there's no requirement to cover mental health benefits federally speaking, but if you do, those type of requirements cannot be held more stringently than those under medical. Where I think it comes up a little bit surprising are where some of these things that you would have to look at from the benefit side of the medical to the mental health side, as you just demonstrated from the visit limits or day limits, let's say, in some of those regards. And so part of that is constantly, I think, looking and reevaluating, not just to see if we're compliant, but as you were talking about, to say, how does this perform ultimately in plan? And part of that is looking at plan design type of issues to see how far does some of this go? And part of that is how rich or perhaps it isn't in certain benefit designs. It's a complex, layered question, I think. But I think one that plans ultimately are reviewing across the board to see, not just from a compliance perspective, but also, as you pointed out, equity.
That didn't help me at all.
I'm sorry.
That's not your fault. Thank you for your answer.
Richard Ward for the record. In our review, there were no, well, we reviewed it as Ms. Dunn mentioned, from the perspective of considering whether the mental health substance use disorder benefits were in parity with, or at least as good as, the medical surgical benefits. And we didn't review as thoroughly or as on a detailed line by line basis in the other direction. There were no apparent inequities in the other direction that leapt out at us.
So just to follow up, so you don't think that it's an inequity that someone who requires, physical therapy for a condition is limited to 60 days versus that same, their friend who has a mental health issue isn't limited? I guess I don't understand how that physical therapy is not considered medical. So I don't really understand. I guess that's my gap in knowledge.
Richard Ward for the record. Within the comparison, the mental health and substance use disorder benefits are compared against a broader range than just physical therapy. So there are a number of other care situations that the plan provides without limitations.
Okay.
So the fact that there's other medical surgical conditions that are within that same of the six categories that are provided in an unlimited manner then that's what applies towards the mental health and substance use disorder benefits. It's a policy decision to consider what you're suggesting, if the physical therapy benefit should be applied with a limitation or not. And customarily, I'll just comment, within other plans that we work with, those physical therapy benefits are provided with a limitation, just in the industry with other state plans.
Thank you. Stacy Weeks for the record. I really appreciate this analysis. I know it's really hard. We're going through a similar process at Medicaid and it's a hard one to do. But I think what I hear you saying is we're not giving folks who have behavioral health needs better benefits necessarily. We're just making sure that the same similar medical component, that they're treated similar, like with equity, right? So it's not like we're improving them to, to be on par as much as we can with what someone would be getting in the medical side for that service. Is that right?
Amy Dunn, for the record, I would agree.
Okay, thank you.
I have one specific question, and it's kind of the same thing. In the other considerations on page 7, the recommendation, so this relates to kind of a treatment plan as well as kind of the doctor's order, if you will. Isn't pre-authorization essentially a treatment plan? And most of, I think, the medical, like many of the medical stuff we cover requires pre-auth. So I guess what's the difference between pre-authorization and this requirement that a treatment plan be provided as well as the doctor's note?
Amy Dunn, for the record, I would actually look to see in the plan documents and others from kind of looking at from those definitional type of things. But to me, I think the treatment plan, I think prior authorization might be a broader term versus.
Richard Ward, for the record, a prior auth
Yeah.
is an upfront review to determine whether the care is appropriate or not. It doesn't automatically come with any sort of follow-through oversight. And a treatment plan is a plan of treatment throughout the course of I need a thesaurus here, or throughout the course of the treatment.
Okay, thank you. I understand that.
Okay. Any further questions? Seeing none, we'll move on to agenda item number 9, discussion and possible action on potential plan design changes for plan year 2025, July 1, 2024 to June 30, 2025. Celestina Glover.
Celestina Glover for the record. So these proposed plan design changes, a number of them came up with the review of our master plan document. We were asked to go back and do some negotiation with UMR for their prescription copay maximizer. And then, of course, the mental health parity. So the first thing I have on the list is the UMR prescription copay maximizer. And in a very simplified nutshell, it's a benefit, it's a voluntary program to provide copay assistance to our members via a coupon program, but it's in the medical setting, not through our pharmacy benefits. Now, the board had asked that I go back and work with UMR on the terms of the contract. Those terms are confidential, so they're not included in this board report. I did provide that to the board members under a separate cover. So if you have questions, I would really appreciate if you don't mention those terms. But UMR is here. They can answer specific questions to this plan design change that we're recommending, if there are any. We can do that now, or we can go through the whole report before we get there. Whichever way we'd like to go.
Any
Okay.
yours to go as you like.
The next thing is the Mental Health Parity and Addiction Equity Act. So based on the report agenda item 8, this is basically a general, we want to incorporate all the provisions of that report to ensure that we can make the necessary plan design changes. And then in the next agenda item, we will talk about how to affects our master plan document. So I just encompass this is to include this item as a general plan design change to ensure we don't miss anything when we actually go through and update our documents. Elimination of prior authorization requirements. I know this has been, this had come up as one of the things. So ambulatory surgery centers, I mean, it's not like somebody's just gonna go, oh, I think I need a knee surgery without going to their doctors. So if they're going to our in-network providers, and even within our UMR network, we do have centers of excellence for some of these services. The recommendation was to remove the prior authorization requirements there. Dialysis also falls under this. I don't know anybody that would voluntarily go into dialysis without the need. And then the final thing that we are looking at is GSA rates for travel benefits. This has come up. In the past, we used GSA rates, then we were told they were taxable. We didn't have a way of doing the 1099s in order to say what was approved beyond, or what was reimbursed beyond the rates allowed. So we're proposing that we adopt the GSR rates, or GSA rates, excuse me. UMR is going to work with us on how we apply the benefit, because in the past it was subject to cost share, and we can work around that. And then internally, we're working on a process because we don't have that many people traveling where we can do the 1099. It'll be a manual process, but we'll be able to create the 1099s to submit to the IRS so that whatever portion is actually taxable, that we're reporting correctly. There's a couple of things that are listed here as what's allowed for travel, bariatric, hip and knee, organ tissue transplant, and abortions. So those are just some of the things that are covered now. This hopefully will help some of our members. You know, it's what we can do and still keep us within our. And with that, I'll put in questions.
Board Member Kelly.
So I think in public comment, we, there was a very articulate, member who talked about, her experience or to date, but talking about the pre-transplant, meetings and counseling, which are currently excluded. And I probably have jumped ahead, but I think since you brought it up, I think, section 4, there's an enhancement to reinstate the travel benefit, but it is excluding those pre-counseling appointments. And just from her description, I heard how complex it is because she's had many of them. But it is concerning that someone who's having, who requires something for life-saving care, where those appointments are mandatory, we're not going to cover travel. Can you talk about that? Can the board change that?
This is Celestina Glover for the record. The board can change that. I mean, it's at the discretion of the board for what they want to include in the plan or not.
I wonder why it's excluded right now. Yes.
You know, I don't have the history on why that's excluded. I would have to go back and look at that.
Stacy Weeks for the record, maybe we look at the fiscal impact a little bit too. I mean, if it's negligible, then I think, it's something we should consider. So I agree with Michelle on this.
This is Celestina Glover for the record. We can do that. I mean, obviously, anything we add to the plan is going to affect our rates, which affects our members. For the second year of the plan, our employer contribution is set. We cannot adjust that. There's no mechanism for us to go back and ask for more money. So from a fiscal standpoint, everything we do potentially increases rates. We also look at cost saving measures. So if this is something the board wants to do, my recommendation would be to include that in the approval of the plan design changes, make that change. And then when we come back with the rates in March, then we can see if there's some way to say, well, adding this back resulted in $1 onto the rate or whatever that is. So it's something we would need to know now because we need to start the rate setting process. We can't bring it back in March. It's too late.
So follow up, Michelle Kelly for the record. I think in an earlier agenda item on the regarding the concierge services, I think Mr. Lindley indicated that in 3 years there's been 4 or 5 transplants. Transplants. So we're not talking a large number. I guess personally, I think we should add it in, but I also see the complexity, and so I wonder if the board or perhaps Siegel, our consultant, could provide some information on what other people do, how we could structure the pre-appointments counselling, just to give us some parameters in which to work, or maybe there are no parameters. I don't know.
We can do that.
Now? Or
This is Celestina Glover for the record. I don't know what other plans provide as far as travel benefits for the pre-surgery visits. It is something we can go back and look at. But if it's a desire of the board that we include it, you can bring it back for informational purposes, but if that's not going to make a difference on what we do to our plan, then I think you could just include that in your motion, that we include that that portion of the travel for that benefit.
yeah, I understand. Okay, thank you.
Betsy Strasberg, I have a question. If the number of incidences of people going through that care is small, can that be handled through an exception process, or does it need to be changed in the plan document?
This is Celestina Glover for the record. We would prefer it in the plan document. To do an exception would mean we'd actually potentially put a hold on every situation, even though it's very limited. You would have to wait for that exception process to be done before that person can move on. And that's not something we want to hang them up on because they're waiting for me or Tim or Nick to say, yes, you can do this. If we're going to allow it anyway, just put it in the plan document.
Thank you.
Yes.
Janelle Woodward for the record. Just a question, this has been brought up in previous meetings, but does PEB ever go and ask for an increase for the second year instead of passing that on to the members, asking legislature not to just give you one amount for both years, but knowing that it always goes up the second year? Can they increase that second year?
This is Celestina Glover for the record. When we build our budgets, we include trend and experience working with our actuaries to determine where we believe rates are going to be 2 years from now. Obviously, we can't be sure.
Yeah.
The employer contribution is not the same in both years. It is more in the second year. But depending on what we do to plan design, the more in the second year may not be enough to cover it. And that means it goes to the employee and the retiree. So it's not, but there is no other mechanism outside of legislature for us to get those employer contributions. So we need to be pretty aware and keep in mind, once we put something in a plan, it's very difficult to pull that benefit back out, even if we decide it's not really working well or it's too expensive. And then we will go forward with the budget build with those new plan design in mind and anything we believe we might anticipate going forward.
Any further questions? Seeing none, it is an action item.
Michelle Kelly for the record. I make a motion to accept what are we reviewing right now?
This is Celestina Glover for the record. The recommendations are numbered at the bottom of the report.
Yes.
So you can take them in that order and make the adjustment for the at the end.
Oh, okay. So Michelle Kelly for the record, I make a motion to approve recommendations 1, 2, 3, 4, as stated in the document. And then should we do a separate one for the travel? Yeah, so I make that motion. Wonderful.
So we have a motion, a second.
Second,
by,
Betsy Strasburg.
thank you. Any further discussion? Seeing none, I'll call for the vote. All those in favor signify by saying aye.
Aye.
All opposed, motion passes unanimous. And second motion,
Michelle Kelly for the record. I make a motion that we approve the recommendation of Executive Officer Glover to use the GSA rates for reimbursement of allowed travel expenses. However, I move that we include medically required pre-transplant appointments and counseling as a covered item for the reimbursement of travel. Is that clear?
we have a motion
Second.
and a second by Board Member Strasburg. Any further discussion? Seeing none, I'll call for the vote. All in favor signify by saying aye.
Aye.
All opposed, motion passed. We'll move on to agenda item number 10, discussion and possible action on recommended changes to updated master plan documents for plan year 2025, July 1, 2024 through June 30, 2025. Tim Langley.
Tim Lindley for the record. This report will go over the benefit changes and updates to the master plan documents and summary of benefits and coverage for plan year 25 for the consumer driven health plan, low deductible PPO, exclusive provider organization EPO plan, dental plan and life insurance, health reimbursement arrangement, flexible spending account, enrollment and eligibility, Medicare health reimbursement arrangement, the health and welfare wrap plans for the active and retirees, and section 125 master plan document. Due to file size, the documents have been provided electronically that are posted online on the website. Throughout the plan year, several intricacies in the plan document verbiage are identified through various methods. These include members notifying PEB, audit reviews, vendor inquiries, etc. PEB staff and its vendor partners review the master plan documents, summary plan descriptions, and summary of benefits and coverages. The proposed changes stem from input received from subject matter experts. Some changes being simply housekeeping efforts, while others are regulatory and compliance matters. The tables and the lists and tables below will review housekeeping changes, board approved changes, changes required per the Mental Health Parity and Addiction Equity Act, No Surprises Act, plan design changes, and other changes deemed necessary for board approval. Throughout the document, the changes have been numbered, and instead of going through over 90 different changes, I would invite the board to have a discussion on specific numbered items. There is no discussion, of course. The board can make the changes as necessary. With that, I pass to the board for discussion, or if they want to discuss a specific item number.
Okay, any questions from the board?
Michelle Kelly for the record. So this isn't a question, but just a general observation that as I was going through, I noticed some typos and things that I just couldn't match up. So I do have some questions that is really kind of busy. It's not going to impact the plan. So with Executive Officer Glover's permission, I'd just like to perhaps communicate with Tim just some of its periods and just not understanding when an asterisk. So it's kind of what would that be? Punctuation driven questions and changes, like nothing that would change the plan design or anything like that.
This is Celestina Glover for the record. Typically, when we do the master plan document changes, one of the things we ask for in the approval of the changes is technical adjustments as needed, and that will cover our grammar and all that, because we will do a proofread in the team once we incorporate all those things and make sure that we didn't miss anything in the process. So, but if you notice something, email us.
Yes, lots of documents.
Yes.
All right, any further questions? Seeing none, it is an action item. Oh, so sorry.
It's okay. It was a last minute hand up. I'm just looking at, this is Jennifer McClendon for the record. I'm looking at 83, and I'm not sure this is the exact item, but renaming the low deductible plan to a PPO plan. I'm just thinking back to Mr. Irvin's public comment about the confusion between having a PPO plan and an EPO plan that is essentially a PPO plan. The last thing that we need is more confusion, I think, in our documents, and but I might not understand the rationale that the team had for coming up with that. So that's just a question, I guess, for Executive Director Glover.
This is Celestina Glover for the record. Because there is no deductible, that was the rationale behind changing it. But of course, the board can approve everything else and not change the plan name. I think Tim has some more information he wants to bring up.
Tim Lilly for the record. One thing that we hear on the quality control side is from our member services unit staff who take calls from new hires, rehires, et cetera. And they always say, why is it called the low deductible plan? There is no deductible. And that's a very common theme that we receive when people are trying to select their plans. And so this was a change brought up by members calling the plan, calling PEB, asking about that. Again, if the board wants to maintain the name low deductible, definitely something we can keep.
Sure. Jennifer McClendon again for the record. I'm just wondering if there might be a third option. Besides, that's maybe a little bit more clear than either low deductible, which it is not, and PPO, which it has in common with other plans. I'm not feeling creative enough to come up with another solution, so forgive me for even bringing up this point.
Michelle
Kelly for the record, I guess, my concern is if we change the name, then, depending on plan experience, most likely soon, and I don't have a crystal ball, but most likely soon there will be a deductible, then we have to change the name again. And so for the short period, there may not be a deductible. I kind of feel that we should keep low deductible and have the explanation because it is unusual for a PPO not to have a deductible. But I will go with whatever the board thinks on them.
Okay, any further questions or comments? Seeing none, it is an action item.
I'm kind of motioned out. What item was I'm sorry, what item was the deductible?
Oh,
83. 83. All right. Michelle Kelly for the record, I make a motion that we accept as presented all changes except for number 83 today. And technical adjustments going forward.
What about 4?
I think we already changed that, right?
Do we have to do it again? No.
Okay, we have a motion. Do we have a second? Okay. Board Member Strasburg seconds. Any further discussion? Seeing none, I'll call for the vote. All those in favor signify by saying aye. Aye. All those opposed, motion passes. We'll move on to agenda item number 11, public comment period. Public comment will be taken during this agenda item. Comments are limited to 3 minutes per person.
Thank you, Mr. Chair. Again, for the record, Phil Welch, BILLWELCH. First, I'd like to acknowledge and thank you all for your time today to hear my wife and myself on our concern. I also want to acknowledge that I did hear the board ask from both PEB and UMR staff for a quality review on the appeal process. I would ask that we make sure that it also includes the exception to plan benefit as part of that review. Having been in healthcare executive for many, many years until I recently retired, I understand that processes are well intended and are intended to meet the needs and the objectives of both the plan and also the member, but sometimes they don't always fall. Those plans are not always followed. And with that in mind, I think the only way you truly get an evaluation is one thing to understand how the process works, but to understand whether it is working, you might want to also request that part of that review includes interviewing plan members who have had to go through that plan benefit appeal process or plan benefit exception process to get a real sense from them if the system is working or not. And so again, thank you very much. I appreciate your time today.
Thank you for your time.
Kent Urban, ERBIN, Nevada Faculty Alliance. First of all, thank you for your action on travel reimbursements. I know Ms. Osborne had to leave for actually a medically related Zoom session. So I hope that message gets to her, and I hope that that goes into effect immediately, or there are plan exceptions for this plan year if need be. Regarding the customer service issues, UMR said their role is to, and I think I get this quote right, quote, support the plan and keep it cost effective, end quote. I would hope that UMR and PEB include the member experience as well as the plan support and cost effectiveness in all of your review. And I appreciate that you're going to review in particular the appeal process in the future. I think that's important, and that it cover both UMR and PEB. Regarding the Medicare exchange contract, you know, the provider via benefit gets kickbacks, commissions from various insurance providers. These are not disclosed to Medicare exchange retirees. I haven't seen a report on their gross commission income recently, but as I recall, it's in millions of dollars. So the service is hardly no cost. This reminds me of the situation in the retirement plan industry 15 to 20 years ago, when providers earned kickbacks, revenue sharing from investment managers and told plan sponsors and participants that their services were free or implied that they were free. The retirement industry has since been reformed, and revenue sharing is now returned to individual participants, and the providers are compensated through transparent contracted fees. It's time for PEB to demand through the RFP process that providers offer their services for a flat fee per participant, and any excess commissions are returned to either participants or to PEB. And if you don't ask for that through an RFP process, they aren't going to offer it. But if you do ask for it, maybe you'll get some proposals from some providers. So that's a suggestion for that RFP process.
You'll be advised